Hello, I'll talk about intravenous anesthetic agent or intravenous hypnotics as we call it. A very important topic, a very clinical topic. So let us discuss thiopentone, propofol, etomidate, ketamine, right? There are few more points apart, there are few more drugs apart from these four. I would later on just add few exam points which are asked on them. But these four drugs, most important. Always a question on IV anesthetic agent asked. These are the four drugs in the option. Okay, so I will compare and contrast them. So let us start with the chemical nature. Thiopentone. Thiopentone is a barbiturate. Propofol, diisopropyl phenol, etomidate, imidazolone derivative, ketamine, phencyclidine derivative. Important. Just trying to show you they are a diverse group. They don't belong to one group. What is the common thing? They all are IV hypnotics. Okay? Appearance. Thiopentone, yellowish powder. It is thio, sulfur containing barbiturate. It is yellowish powder. And we have to reconstitute it by mixing normal saline or distilled water because pH of the drug is very high. pH is more than 10.5. So either normal saline or distilled water is used. Okay? Remember, propofol and etomidate, both are milky white in color. Okay, etomidate has a transparent variant also available, but it is milky white in color also. So propofol is always milky white. Etomidate has both transparent and milky white variant available. Ketamine, transparent liquid. Okay. So appearance, right? Questions are asked on appearance. That which of the following is a drug is milky white in color, or a vial of a drug can be given and they can ask you which drug is this. If it is milky white, propofol in the option, always answer would be propofol. Okay. Then next point, additives. Any additive added in the main drug. In thiopentone, we have anhydrous sodium carbonate added. Why anhydrous sodium carbonate is added? To keep it soluble in the liquid form, in the aqueous form. Well, when you prepare it in the aqueous form by mixing normal saline, the drug becomes active and it can react with the carbon dioxide and form a precipitate. This anhydrous sodium carbonate absorbs the carbon dioxide of the air and prevent this reaction to happen. So this anhydrous sodium carbonate is added to maintain solubility, right, of drug. To maintain solubility of drug. Okay. In propofol, three very important additive is added. In the vial of propofol is, as we have written, diisopropyl phenol, which is lipid. So lipid is not soluble intravenously. So three things are added in propofol. To remember the three additives of propofol, remember the word eggs. E-G-S. E for egg lecithin. G for glycerol. And S for soybean oil. Now, why are these three added? Why are these three added in propofol? These three are added in propofol as an emulsifying agent to make it soluble intravascularly. So these are emulsifying agents. Very important. So propofol has egg lecithin. So it has egg, let's say, lecithin added to it, not the complete egg. And we are allergic to avidin, protein and polypeptide of the egg, not lecithin. So propofol is not let's say, contraindicated technically to a person who is allergic to egg, but still it is being carried out from ages. The propofol should not be given to a person who is allergic to egg. So keep this in mind. Technically, clinically, we are not bothered by that person has an egg allergy before giving propofol. But for exam question, keep it in mind, propofol should be used cautiously in patient with egg allergy. If no other option is matching with the propofol, only egg allergy is matching, go for it. I'm telling you to remember this wrong thing because questions are based on this. I have seen question being formed like this, but clinically, we are not bothered. It is not causing problem in person who is allergic to egg. Okay. These two, no such additive added, which needs to be discussed. Okay. The routes of administration. For thiopentone, IV only, intravenous we can give. And what is the onset of action on IV dose of thiopentone? The onset of action is within one brain arm circulation, 11 to 14 seconds. Within one brain arm circulation, when you give the drug intravenously, how fast it reaches intravenously in the vein of the upper limb, how fast it reaches the central nervous system is one brain arm circulation, and it is 11 to 14 seconds. So onset of action is 11 to 14 seconds. Propofol is also given IV. Onset of action 30 to 60 seconds. Etomidate also given only IV. Onset of action 30 to 60 seconds. And ketamine, it can be given IV, it can be given IM, it can be given oral, and it can be given rectal. It can be given by multiple routes. Onset of action varies from different routes, but IV is what I am writing, is 60 to 90 seconds. Okay. So one question is asked, two questions from this point. First, fastest induction agent. Answer is thiopentone. Fastest agent is thiopentone. Okay. This is question. And the second question which is asked, routes by which ketamine can be administered. Go for all routes except subcutaneous. You cannot give the drug subcutaneous if you want a fast action because it is not a vascular area. So routes of ketamine has been asked very frequently in exam. Okay. So this is routes and the onset of action. Now duration of action. Duration on single dose. I talked in the introduction that for induction we give a dose, patient becomes unconscious, and for maintenance we have to give a continuous infusion of IV anesthetic agent. Okay. Why continuous? Why? What is the duration of action of single dose? Remember, for all of them, the duration of action on single dose is for 6 to 8 minutes only. Only for 6 to 8 minutes. Remember, only for 6 to 8 minutes. Why? Why their duration of action on single doses only for 6 to 8 minutes? So many times in exam it has been asked. Why is thiopentone ultra short acting? Why is there a rapid awakening after single dose of thiopentone or propofol or etomidate or ketamine? Well, the answer is always one, redistribution. The drugs get redistributed. Okay. So answer is redistribution. Redistribution. Right? So answer is redistribution. Okay. Keep it in mind. Okay. All these drugs redistribute. When you give it, they go to the target organ, that is brain, attaches to the receptor, and once serum concentration decreases, comes back from that receptor, detached from the receptor, and gets redistributed to lesser perfused organ. The redistribution. Okay. So remember this. The final metabolism of the drugs are delayed. It varies from drug to drug, but all of them gives a rapid awakening because of redistribution. Okay. Now metabolism. Metabolism. How are the drugs metabolized? Now remember, thiopentone, liver and kidney. Metabolism is by liver and kidney. Okay. Completely depend upon liver and kidney. Propofol, liver and kidney. 80% of the drug is metabolized, and extrahepatic, extrarenal, 20% more drug is metabolized. Extrahepatic, extrarenal, 20%. Okay. 20% more drug is metabolized by extrahepatic, extrarenal route. Okay. So it has both liver and kidney route also and extrahepatic extrarenal route also. In case any problem happens in liver and kidney, the extrahepatic routes take over. Drug never accumulate in the body. Got it? Okay, etomitate liver and kidney. Liver and kidney. Okay, ketamine, liver and kidney. So only it is propofol which has an extrahepatic extrarenal route of metabolism. So in patient with pre-existing liver and kidney dysfunction, this agent would be very, very suitable. Got my point? Okay.